Welcome to this deep dive. Today, we're really tackling everything you wanted to know about estrogen therapy. We'll be sifting through your provided sources.
Yeah, bringing you the clearest picture possible.
Exactly. We'll explore some of the myths around feminizing hormone therapy for transgender individuals, estrogen's role in menopause, and its broader impact on health for cisgender women, too.
Right.
Our goal is basically to extract the key insights, separate fact from fiction, and help you get a clearer understanding of this hormone.
And we've got a really comprehensive set of materials to work with today. It's quite a stack.
It looks like it.
Yeah, we've got excerpts on misconceptions about feminizing estrogen therapy, a systematic review looking at psychological effects for trans individuals,
Okay.
several pieces debunking common estrogen myths like, breast cancer and weight gain.
Yeah, the usual so-so.
Definitely. Then discussions on why natural feminization isn't really a viable path, details on effects and administration for gender affirmation, an explanation of estradiol's role, comparing different administration methods, and some really important perspectives on hormone replacement therapy during menopause that challenge some old beliefs.
Okay, let's unpack this then. A big topic that comes up right away is feminizing estrogen therapy and fertility for transgender individuals. We've got sources highlighting a major misunderstanding here.
Precisely. One of the most prevalent myths, and it's covered in 7 myths about feminizing estrogen therapy and backed up elsewhere, is this idea that starting estrogen just automatically means infertility.
Right, that it's sort of a switch being flipped.
Exactly. But the key takeaway here, and it's crucial, is estrogen is not birth control for trans folks. Estrogen therapy on its own does not stop sperm production.
So it absolutely shouldn't be relied on for contraception.
Absolutely not. That means, even while someone is undergoing feminizing hormone therapy, the possibility of causing a pregnancy still exists.
Go, that's a critical point.
It is, but it's also really important to understand, as your sources emphasize, that we don't have, comprehensive long-term data on exactly how hormone therapy impacts fertility years down the line.
So there's still some uncertainty there.
There is. And because of that potential long-term impact on the ability to conceive using one's own genetic material, the strong recommendation is always to consider sperm preservation before starting.
Planning ahead, basically.
It's all about planning ahead for future options, keeping those doors open if possible.
That makes total sense. The better to have options. Interestingly, I saw in the Wikipedia entry, there's some research mentioned about potentially restoring fertility using something called clomophene. Is that right?
Yeah, clomophene. What's fascinating here is that while the standard medical advice quite rightly focuses on the potential for long-term changes and the importance of preservation, there is indeed emerging research, like the work highlighted in Wikipedia referencing Dr. Will Powers, exploring using medications like clomophene to potentially, kickstart sperm production again.
But it's not quite mainstream yet.
Exactly. It's crucial to approach this with caution. It's not yet a widely established or universally effective method. The primary message really remains the potential for reduced fertility and that proactive step of sperm preservation.
Got it. Okay, moving on then, let's delve into how hormone therapy impacts the mental well-being of transgender individuals. We have that systematic review in our sources.
Yes, the review titled A Systematic Review of the Effects of Hormone Therapy on Psychological Functioning and Quality of Life in Transgender Individuals. It specifically set out to, rigorously investigate this connection.
And what did it involve?
They analyzed 3 prospective cohort studies. These followed 247 transgender adults, mostly transitioning from male to female, as they actually began hormone therapy.
Okay, prospective studies. And what did they find? Did the therapy generally seem to help with mental health?
The results were generally quite positive. 2 of the studies showed significant improvements in psychological functioning, specifically a reduction in feelings of depression and anxiety.
When did they see these improvements?
At both the 3 to 6 month mark and then again at 12 months after starting therapy.
Okay. And the third study?
The third study indicated that quality of life improved at 12 months for both transmasculine and transfeminine individuals. But it's interesting, only the male to female group showed a statistically significant increase in their overall quality of life.
Huh. That's an interesting distinction. But overall, it really highlights the potential of hormone therapy to alleviate that psychological distress, the gender dysphoria.
Exactly. For many transgender individuals, the physical changes from hormone therapy are considered, medically necessary, a key step to alleviate this distress.
Which can then impact other things too, right?
Absolutely. It can reduce the risk of other mental health challenges and significantly improve their overall quality of life. And this aligns perfectly with clinical guidelines like the WP Path Standards of Care, which recommend hormone therapy for these very reasons.
Right. However, I seem to recall the review also pointed out some limitations in the evidence they looked at. It wasn't perfect.
No, and that raises an important question about just how strong the evidence is. The review itself concluded that the overall quality of the evidence was, well, low.
Low. Why was that?
Mainly because the studies didn't have control groups or use randomization. Plus, they relied heavily on participants' self-reported experiences.
Ah, okay. Self-reporting can be tricky.
It can be. So while the findings suggest hormone therapy likely has a positive impact on psychological well-being, within that 3 to 12-month time frame, we really need more robust research to solidify these conclusions, more controlled studies.
Understood. Okay, let's switch gears now and address some of those common myths about estrogen, but this time in cisgender women. We have a couple of sources tackling misconceptions around breast cancer and weight gain.
Yeah, and here's where it gets really interesting because, like you said, a lot of what we commonly hear doesn't quite match the more nuanced understanding we have today.
Starting with breast cancer, the idea that estrogen causes it.
That's the big one. But the evidence, as highlighted by Women First of Louisville, actually points, well, in a different direction. Some data even suggests estrogen supplementation after menopause might have a slight protective effect.
Wow, protective. That's completely counterintuitive to the common narrative. So where did the link idea come from?
Well, think of it like this. An analogy might help. If you have a garden with some weeds already present, adding fertilizer can help those weeds grow faster, right?
Okay.
Similarly, persistently high levels of estrogen can sort of facilitate the growth of already abnormal cells in the breast. But the estrogen isn't seen as the initial cause, the thing that starts the abnormal cell.
So it's more like fuel for an existing fire, not the spark.
Exactly. It's more about providing an environment for growth rather than initiating the problem. Plus, the connection often gets confused with the effects of synthetic progestogens, which are sometimes used alongside estrogen in older forms of hormone therapy.
Ah, okay. The synthetic progestogens issue comes up again.
Mm-hmm.
And what about the other big myth that estrogen leads to weight gain in cisgender women? Very common belief.
Again, the reality seems to be pretty much the opposite. Estrogen actually plays a role in making the body better at processing carbohydrates, more efficient.
Better.
Yeah, and it's associated with that more typically feminine body shape, particularly around the waist. In fact, your sources from both Women First of Louisville and Inner Balance really emphasize the positive roles estrogen plays in metabolism.
Positive roles. That really goes against what so many people assume. Tell me more.
Absolutely. Estrogen helps the body become more sensitive to insulin, which is good for blood sugar control, and it promotes a smaller waist-to-hip ratio.
Okay.
It also aids in maintaining lean muscle mass, and muscle burns more calories, right? It even influences appetite regulation through interactions in the brain and with hormones like leptin and ghrelin.
So it affects appetite too.
It can. It might also improve mood, potentially reducing emotional eating, and it encourages fat storage under the skin, subcutaneous fat, rather than the more harmful visceral fat around the organs.
So where does the weight gain idea come from then, if estrogen isn't the culprit?
Well, the weight gain that's often blamed on estrogen is actually more likely linked to progesterone, especially the synthetic progestins found in some types of birth control. That's a common source of confusion.
That is fascinating. So estrogen has a much more intricate and often beneficial impact on metabolism than we typically hear.
Okay, shifting focus back now to feminization for transgender individuals. We have a source that sort of debunks the idea of achieving significant changes through natural methods.
Yes, this is a really important point for transgender individuals to be aware of when they're considering their transition options. The article from Plume directly addresses this misconception that diet alone or supplements can lead to significant feminizing hormonal changes. So all those claims about, eating vast quantities of certain foods or taking specific supplements,
Yeah.
generally not true for real hormonal shifts.
That's right. The sheer amount of food you'd need to consume to have any kind of meaningful hormonal impact is usually just unrealistic, and probably not nutritionally sound either.
Like the examples they gave.
Yeah, the article mentions people trying things like eating massive amounts of carrots or cinnamon or chia seeds. These simply aren't going to produce significant, measurable feminizing effects comparable to medical therapy.
And what about the risks? Trying to pursue a natural transition using herbal supplements. Is there a downside?
Oh, absolutely. Here's where things can get really concerning, actually. Herbal supplements are regulated very differently than FDA-approved medications. Much less oversight,
Less testing.
way less rigorous testing, which opens the door to several potential problems. Things like adulteration, where supplements might be contaminated with harmful substances like heavy metals. Yeah. Or inconsistent amounts of the active ingredient, so you just don't know what dose you're actually getting. Variability in potency depending on how it's prepared.
It sounds really unpredictable.
It is. There can also be outright falsification, where it might not even contain what the label claims, difficulty even identifying the correct plant source sometimes, potential interactions with other medications.
Drug-herb interactions.
Exactly. And just like prescription drugs, they can have their own unwanted side effects. So the clear message really is that a monitored, safe transition with predictable, real results is best achieved through medical hormone therapy under a doctor's care.
That's a really crucial distinction to make for safety and efficacy. Okay, so now let's talk about what does happen with medical feminizing estrogen therapy. What kind of timeline can people typically expect for those changes?
Our sources from UCLA Health and Wikipedia give a pretty good overview here. Estrogen therapy starts a range of feminizing effects, but the timeline for these changes can definitely vary from person to person.
Okay, so what are some of the first things people might notice?
Well, breast growth usually starts within about 3 to 6 months. The most noticeable development tends to happen over, say, 2 to 3 years.
And other physical changes.
Decreases in testicular size and sperm production also begin within a similar time frame, 3 to 6 months. Although it can take longer, possibly more than 3 years, for sperm production to fully cease, linking back to our earlier point about fertility.
Right. What about changes in hair growth and skin texture?
You'll typically see a thinning and slowing of facial and body hair growth starting around 4 to 12 months. More significant changes happen over 3 or more years.
Yeah, but it doesn't just disappear.
No, it's important to remember that while the hair might become finer, grow more slowly, complete removal often needs other methods like electrolysis or laser hair removal.
Makes sense. And on the head, hair loss.
On the scalp, male pattern baldness might slow down or even stop progressing within maybe 1 to 3 months. But unfortunately, estrogen therapy alone generally won't cause significant regrowth of hair that's already been lost.
Okay, managing expectations there. And skin.
Skin softening is another common change, often becoming noticeable within 3 to 6 months.
And what about overall body shape? Fat redistribution.
Yeah, fat redistribution typically begins around the 3 to 6 month mark as well, and that can continue for quite a while, maybe 2 to 5 years, leading to a more typically feminine pattern of fat storage, like on the hips and thighs.
And muscle mass.
Muscle mass and strength tend to decrease, starting within 3 to 6 months, with the most significant reduction happening around 1 to 2 years. There might also be some widening or rounding of the pelvis, but that's generally only a permanent skeletal change if it happens before someone has finished puberty.
Gotcha. The UCLA source also mentioned some effects that are not influenced by hormone treatment. While our specific excerpts didn't list those examples, it's a good reminder that, hormone therapy has limits. It doesn't change everything.
Absolutely. It's also important people are aware of potential changes in mood, maybe increased emotional reactions. Though it's worth saying, many individuals report an overall improvement in their mental well-being.
That's good to hear. And other potential side effects.
Decreased sex drive and changes in erectile function are also commonly reported effects that people should be aware of.
Okay. Now let's get into the specifics of estradiol itself. That's the main estrogen we're talking about, right? How it's administered, the risks.
Yes, estradiol. It's indeed the most potent and the most abundant natural estrogen found in cisgender women during their reproductive years. And it plays crucial roles in loads of bodily systems well beyond just the menstrual cycle.
And its role changes after menopause.
Right. As the Stat Pearls article explains, its levels drop significantly during menopause, and that drop is what leads to many common menopausal symptoms. So supplemental estradiol can effectively manage these symptoms, and it's also used for other conditions involving low estrogen or hypoestrogenism.
Okay, and we've seen There are various ways to give estradiol, especially for transgender women. What are the key differences there, the pros and cons?
So our sources highlight several routes: oral pills, sublingual tablets that dissolve under the tongue, transdermal patches or gels applied to the skin, injections, and even implants.
Okay, lots of options.
Yeah, and a really key concept to grasp here is the first pass effect, mainly with oral estrogen, as Very Well Health explains it.
The first pass effect. What's that?
Think of it like a toll booth, maybe, in the liver. When estrogen is taken by mouth, it goes straight to the liver to be metabolized before it enters the general bloodstream.
Ah, so the liver gets the first crack at it.
Exactly. And this process significantly reduces the amount of active hormone that actually reaches the rest of the body, its bioavailability, which means you often need to take higher doses orally to get the desired effect.
And those higher doses come with risks.
Potentially, yes. These higher oral doses can be associated with an increased risk of things like high triglycerides, gallstones, and potentially even heart disease and blood clots in some individuals.
So are the other methods generally safer then? Because they bypass the liver initially.
Generally speaking, yes. Sublingual, transdermal, and injected estradiol largely bypass this first pass effect, which means you typically need lower doses to achieve the target hormone levels, and they potentially carry fewer risks, particularly concerning blood clots and cardiovascular issues. Both Very Well Health and the Helio article point to transdermal and injected estrogen as generally safer alternatives to oral for this reason.
But are there downsides to those methods?
Well, it's worth noting they might result in less consistent estrogen levels throughout the day compared to taking a pill regularly. You can get peaks and troughs, especially with injections.
Okay, so it sounds like the non-oral routes, parenteral routes, are often preferred for transgender women.
That tends to be the general consensus, yeah, primarily due to that minimized cardiovascular risk profile.
Right.
It's also interesting, as Wikipedia mentions, that the estradiol levels often aimed for in transgender women before they have surgery like a gonadectomy, those levels are often higher than the typical replacement doses used for cisgender women in menopause.
Why is that?
Because those higher doses are needed to effectively suppress testosterone production. It takes more estrogen to overcome the body's natural testosterone output.
I see.
So while the Endocrine Society might suggest target estradiol levels around, say, 100 to 200 picograms per milliliter for trans women, their recommended injection dosages sometimes need to go higher than that to achieve adequate testosterone suppression. It's a balancing act.
Makes sense. And do different methods get processed differently beyond the first pass effect?
Yeah, there are pharmacokinetic differences, like sublingual or rectal administration can lead to higher peaks and lower troughs in hormone levels, and oral estradiol results in a higher ratio of estrone, another weaker estrogen, compared to estradiol in the bloodstream. These nuances matter for monitoring.
Okay, that's quite detailed. Finally, let's tackle the use of HRT, hormone replacement therapy, in menopause and debunk some of those myths around its risks. This has been a really debated topic for years.
Absolutely. And the controversy largely stems from that big study back in 2002, the Women's Health Initiative, or WHI. It initially reported increased risks of heart disease, stroke, breast cancer associated with HRT. Caused quite a stir.
A huge stir. But our sources from Vital Living and Henry Ford Health suggest that study had some significant limitations, right?
It did. Looking back, several factors contributed to what we now understand were somewhat, well, maybe misleading or overgeneralized results.
Such as?
Well, the average age of the women in the study was quite high, around 63. Many were already quite a few years past the start of menopause.
Okay, so not necessarily women starting HRT right at menopause onset.
Exactly. Many also had pre-existing health conditions. And critically, the study primarily used oral conjugated equine estrogens derived from horses and a specific synthetic progestin medroxyprogesterone acetate in a combination product called Prempro.
Not the bioidentical hormones often used today.
Right. Those have different effects. Plus, the study initially grouped all participants together, so it didn't properly differentiate between women who'd had a hysterectomy and were taking estrogen alone versus those with a uterus taking the estrogen-progestin combo. The risks turned out to be quite different for those groups.
Okay. So how has more recent research changed our understanding?
More recent studies and reanalyses of the WHI data itself have really challenged and, in many cases, corrected those initial broad-stroke findings. We now have research suggesting HRT can be safe and even beneficial for many women.
Especially under certain conditions.
Yes, especially when it started earlier, typically within 10 years of menopause onset or before age 60. That timing seems crucial.
And benefits.
Some studies actually indicate a protective effect on the cardiovascular system when HRT is started early in appropriate candidates. And interestingly, estrogen-only therapy for women without a uterus has even been linked to a decrease in breast cancer risk in some analyses of the WHI data and subsequent studies.
A decrease. Wow. So the breast cancer risk wasn't universal.
It seems the increased breast cancer risk seen in some HRT studies is more strongly associated with the use of those synthetic progestins, like the one used in the WHI, rather than bioidentical progesterone.
That's a key distinction.
It really is. There's also growing evidence suggesting potential benefits of early estrogen therapy for brain health, possibly reducing dementia risk. And importantly, transdermal estradiol, the patch or gel, does not seem to increase the risk of blood clots or stroke in the same way that oral estrogens might. That bypasses the liver effects again.
So we also have better formulations now, too.
Definitely. Newer HRT formulations are available, lower doses, different delivery methods like patches, gels, rings, including FDA-approved bioidentical estrogen and progesterone. These can offer effective relief from menopausal symptoms with potentially fewer side effects.
What about compounded bioidenticals? Are they safer?
That's a common perception, but it's important to be cautious. Compounded hormones aren't FDA approved and don't have the same rigorous oversight for consistency and purity. FDA-approved bioidentical hormone formulations offer the same molecular structure, but with regulated manufacturing and known dosages, carrying the same potential benefits and risks as other approved HRT options.
So the narrative around HRT risks has really evolved quite a bit since 2002.
It absolutely has. The key takeaway is that the risks and benefits are complex. They really depend on individual factors, age at starting, the specific type and dose of hormones, the delivery method, personal health history.
It's not one size fits all.
Not at all. The widespread fear generated by those initial WHI headlines just doesn't hold up against the more current, nuanced research we have now. It requires a personalized conversation with a healthcare provider.
Well, this has truly been a deep dive into the world of estrogen therapy. We've covered a huge range from feminizing therapy for transgender individuals right through to hormone management during menopause for cis women.
We really have, and I think we've seen just how complex estrogen therapy is. The effects differ significantly depending on the context, gender affirmation versus managing menopause symptoms.
Definitely.
And the specific type of estrogen, how it's administered, individual health factors, they all play crucial roles. It's also become clear that many of these long-held beliefs about estrogen are, well, actually myths that have been challenged or refined by more recent, more detailed research.
Absolutely. So considering the really profound impact estrogen has on so many different aspects of health and well-being, and given our ever-evolving understanding of its role, what further questions linger for you, thinking about its use and long-term effects across these different populations?
Yeah.
What avenues of research or maybe personal exploration might you feel compelled to pursue next?